There you go. So she already covered all this stuff, all the other things that I do in this life. I want you to meet my friend Andy and her family. And I use the term friend loosely, and you'll see why later on. Um, Andy's 72 years old. She's a retired ED physician. She's married with a husband and a couple of kids, a couple of grandchildren. She likes all the things that people like to do. And she's seen a lot in her career. This is her husband, John. He's almost 80. He's retired. He is an adventure traveler. So he retired before Andy did, and he's kind of waiting for her to join him. Yeah. I live in a ski town, hence the picture. This is Stephen and Abby. These are their grown children. Abby has kids. I don't think Stephen has kids yet. There's no thought to their mom or their father or them experiencing illness or death. And for them, life is good. Everything's just sailing along beautifully. So medical aid in dying. I'm not going to use that full term. I'm going to use MAID. That's what we call it where I'm from in Colorado, and that's our law is named medical aid in dying law. It's an end-of-life option for individuals who are eligible to receive that kind of care. And for those that choose MAID, they say that it offers them dignity, choice, and control over how their life ends. And you know, I would say it offers them the illusion of these things because none of us truly have control over any of it. Where medical aid in dying is legal, recipients have to be adults. They have to be terminally ill with a prognosis of 6 months or less to live. In most jurisdictions, they have to be enrolled in hospice. They have to have capacity, be able to make their own medical decisions, and they have to be able to physically self-ingest the medication. It differs, but most states make a cocktail with benzos, basically, and you drink it down. It's about 6 ounces of liquid. It's a one-size-fits-all kind of a cocktail in most places. And so 6 ounces, although it sounds like a lot, is basically enough to kill an elephant or a mouse and whatever you happen to be in between. In 2016, in Colorado, voters approved this particular statute that allows a terminally ill patient with certain prognoses, 6 months or less to live, to self-administer and to voluntarily end his or her own life, their own life. It authorizes the physician to prescribe the medication under certain conditions, and it creates criminal penalties for tampering with the person's request. There are criminal penalties for family coercion of a person, and it's happened a few times where folks have said, "Wait a sec, they really did convince their family member to do this, and that can't be right." I don't know of a single case yet, and I've been looking where a physician or a provider has been implicated in any kind of coercion with a patient. So again, eligibility greater than 18. In Colorado, you have to be a resident for greater than 6 months. In Vermont and Oregon, they have a bit of a tourism industry going. Over the last few years, they've eliminated the requirement that people come to live there. My daughter, when she was 24, was diagnosed with a rare cancer and given about a year to live. And she said, "Mom, we're moving to Oregon." At the time, they weren't sure that she would even make the 6 months. She's fine now, by the way. Not fine, but she's good. 10 years. She's 9 years past her warranty. 9 years past her warranty at this point. But she talked about moving to Oregon because she wanted some control over the end of her own life. And that's when I started to get interested in what people think about this, how they process the information about their own deaths and how they want to participate or if they want to participate. So capacity is a big deal. You have to have the ability to make your own healthcare decisions and to be able to give informed consent, which means you're capable of understanding MAID, you understand its implications, you understand the alternatives to MAID, and you understand the risks and benefits of taking this cocktail. So, and then again, I said you had to be self-administering and enrolled in hospice in most jurisdictions. I think there's 1 or 2 where you don't have to have a hospice diagnosis, but palliative care will help guide you in the process of medical aid in dying. Patients can opt in or out at any stage, and this is really important. It turns out that many people who are eligible and who receive the prescription and have it in their home, they don't ever use it. They want it there just in case. It's a comfort measure in some ways. But of course, there's always a tension of knowing if a person opts for medical aid in dying and they want to take the cocktail, that tension between when is the right time? Am I going to be too late? Am I not going to be able to raise a cup to my mouth? Am I going to vomit as soon as I ingest this thing? So that's the patients that I have enjoyed working with who have taken this option. That's their biggest difficulty with this. The difficulty is not in making the decision. There's difficulty in informing a family and helping talk with their people about it. But there's also this tension of, will I be able to do it at the end? Some Colorado statistics, because this is all I have. There are no states that require data gathering. This was from survey data. No states require gathering any information about what happens after a person is given the prescription. The pharmacies can tell you when a prescription has been made and filled, but that's all we have. But this was a survey, bunch of physicians, 81% indicated a willingness to discuss medical aid and dying. More people were willing to refer it off to someone else. Colorado law requires both an attending and a consulting physician for every MAID case, with a gap of time in between. Colorado law does not require a psychological evaluation. Most states don't, unless the person clearly has a need for a psych eval to begin with, and then they'll have that done before a prescription can be written. Most people who use medical aid in dying die at home or at a private residence, a friend's house, someone's back garden. This has happened. It's allowed in nursing homes and hospitals. Most are happy to allow you to take advantage of MAID in their facilities. Some of the Catholic hospitals are beginning to make more of a stand about that. There's you all know the news. Yeah. By far, the largest number of MAID recipients are over 65 years old. Most are for cancer patients. Many people, comparatively so, 18% of MAID prescriptions are written for neurodegenerative disease patients, and the remainder is among folks with cardiovascular disease. That's problematic because it's hard to say with a cardiovascular disease patient that it's hard to give them a 6-month prognosis. A person can live for a very long time with heart and pulmonary failures. So that's a tougher sell, but folks do use it. And as I said, there's no requirement to report that a person actually uses the prescription. So it's hard to know much more beyond these statistics. But anecdotal evidence suggests that about 45% of the folks who ask for, qualify, and receive the prescription, they never use it. I have a client that had a dog that died, and when the dog died, they had a little pot made in the shape of the dog, and the dog's head was a lid. You take it off. So she got the medication, and she put it inside the dog and put the head back on. And every time she was thinking, like, is this the time? Should it be next week? Should it be this week? She'd look at the dog and she'd ask her dog, can you please help me make this choice? She ended up never using the medication, actually. She died under her own steam. So back to Andy. Andy's going about her life, and she gets a devastating diagnosis of metastatic ovarian cancer. She goes through the process. She exhausts all of his standard therapies over the course of a couple of years. She participates in a clinical trial. She fails it, but she's all about it because maybe it'll help somebody else that she might know or might not know. And her cancer comes back, and she talks to her family. She tries to talk to her family about medical aid and dying. She's seen a lot. She's an ED physician. She's seen all different ways of dying, and she's kind of cataloged over the years. I don't want to go that way. No, that way I don't want to go. Don't want to drive into a bridge abutment. Don't want to die. And she didn't want to die under hospice care. I'm not really sure why. I never really got to the bottom of that. And you'll see about Andy later. So how do we reconcile MAID in these contexts? The practice of medicine, do no harm. That'll come up again and again. The practice of religion. Our cultural philosophies, everyone talks about the end of life in culture and religion. We all have different philosophies. The ethics of medical aid and dying, very controversial, lots of really rich information and opportunity for conversation, which I hope in your questions you'll bring up. And then our human lived experience, how do we reconcile MAID in the way, given that humans have an incredible will to live? In the Hippocratic Oath, the classical version, it literally says, I will not give a drug that is deadly to anyone if asked for it, nor will I suggest a way to such a counsel. Religious concerns, in every religion, there's some kind of a suggestion about how death should take part. And the ideas, the underlying philosophies there are that life is a gift. It's a gift from God. It can only be taken or given by God. And that suffering is a key to salvation. I think about suffering a lot. I've had a lot of I kind of joke, it's not really funny, but I joke and say that I know more dead people than alive people in my family, in my inner circles. And so I think about suffering and I watch it in people. You know, religion can give us some salve for that, but I'm not sure it's the only answers. So MAID lives somewhere in between one's intent to take one's own life and another's intent to take a life. So in the philosophy and the ethics of this, you know, there's this balance. I want to take my own life. My physician isn't going to take my life necessarily. Is my loved one, is my partner gonna be that person? Where is that balance? Where does it live in there someplace? And that's, I think when people consider MAID in their own lives, they're not really thinking about the philosophy or the ethics of it, or their religious beliefs, or the cultural beliefs. I think they're just wanting to end their own suffering. And so all of this stuff is sort of the underpinning. It's not that, you know, people don't talk to their families about, you know, gosh, let's talk about the ethical concept of autonomy. Am I actually meeting that? So the philosophical loophole is suffering. Is the practice of medicine meant to alleviate suffering? Does religion have a role in ameliorating suffering? Most people think it does. And does the individual have the right to address their own suffering? I think that's the crux of the question with respect to MAID. And I'm not actually sure. I'm not here to tell you that's the right, you know, right or wrong thing to do. I don't really know. I think it depends. So John is struggling. He says, you know, what will our friends think? I just am not in favor of suicide. I think there's stigma attached to it. He says, you know, will people think that I coerced her? And the backstory here is the patient that this is based on. They'd had a bunch of trouble in their marriage. There was some abuse early on. They stayed together for a very long time. But he thought, it's totally normal. My friends are going to think that I twisted her arm because it's annoying having a dying wife. And then his other thing was, what if a new drug is discovered tomorrow? Like, shouldn't she be allowed to take advantage of that? I know I've lived that in my own family. I read these news stories and I see, oh my gosh, there's a new treatment for this, and my so-and-so didn't live long enough to participate in that. Damn. And then, of course, the question of euthanasia. Is this like putting down a dog? I want to present just a brief ethical framework for thinking about medical aid in dying. There's lots of principles in ethics, and these are the four main ones: autonomy, beneficence, non-maleficence, and justice. And you can, you know, you've probably most everybody has run into this, or maybe you haven't. Individual choice and informed consent, is medical care in the best interest of the patient? Do no harm comes up over and over. And the justice argument is one that I think about a lot. The fairness in administration of healthcare. I'm going to kind of fly through these because I'd rather hear your thoughts than any more of my own, really. And there's more slides to get through. Let's see, is there anything really important on here that I can blow through this? Beneficence, medicine strives to offer the best treatments possible, given a situation. It's not always possible. What about in the case of futility? What happens when the best care can no longer prolong a person's life? What happens when the best care actually threatens a person's well-being? And I think as patient advocates, we've all run into that, where a person is sicker because of what they're doing than what they didn't do. But so the non-maleficence part is the do no harm part. And this is really subjective. It's based in the personal and the clinical experiences of patients and clinicians. And there's tons of published research. If I take this drug for my cancer, what are the side effects? That's basically a harm. What are the harms? What are the risks versus the benefits? And what if the treatment is the harm? Is it harmful to continue to treat a patient who can no longer benefit? Is death the ultimate harm? I think to some people, death is the ultimate harm. I think to other people, they're like, yeah, next adventure, what's after this? I think I'm in the second camp. So MAID is concerned with justice, and this is one that I think about a lot, like I said. It considers the allocation of resources. There's this slow medicine movement. Have any of you heard of the slow medicine movement? It's kind of an interesting thing. People decide at a certain point, age 65, age 75, age 85, whatever, pick your number, that they don't want to get any more screenings. They just are going to let nature take its course. You see this with a lot of folks. There was a pretty good article, was it in the New Yorker, I think. I don't know if anybody saw that, that a close relative recently used to tell his doctor, I don't want to be treated anymore. And he died within 48 hours of showing the attending that article. He just said, you know, I don't need this. And there are other people that need it more. There are shortages of medication, you know, shortages of ovarian cancer drugs specifically. And staffing shortages. We saw that with COVID. So anyway, that's an issue. The justice issue, I think, is real interesting, and it has to do with slow medicine. MAID also distinguishes intent. There's a moral distinction between causing the death of someone and hastening a death of someone. Maybe doing nothing is hastening someone's death. It's unclear. Every case is different. Intent is active. It's an action that is considered and taken by an individual on their own behalf, like ingesting a drug cocktail or choosing to end futile care. I want to touch on language for a second. When you talk about end-of-life choices, all of these phrases are used. Aid in dying, right to die, death with dignity, choice, end-of-life options, suicide, assisted suicide, euthanasia, mercy killing, assisted dying. All of those are used to in varying ways, pejoratively mostly, on the bottom ones and maybe positively on the top. So back to Stephen and Abby. They're having a conversation. And Abby says, it's mom's decision and it's her right. And Stephen says, there must be more they can do. Abby says, yeah, mom's too weak to have more treatment. And besides, there's drug shortages. The drug that was keeping her, that could keep her cancer not in remission because it never would have been. She was too sick. But that drug, it's not available to everybody. And he said, well, mom should get it. She's a doctor. So there's that whole thing about who's more important and who's less important and how do we allocate some of the scarce resources. And Abby says, yeah, but in the end, it's her choice. And he says, yeah, but isn't this suicide? And she says, mom wants to know she has some control. And Stephen says, she's a human, not a dog. We don't just put her down. And Abby's remark was great. Mom shouldn't suffer. She deserves the same dignity that we've given our dogs. Stephen says, can't she just go on hospice? I hear this with end-of-life clients and their families in every conversation. Can't she just go on hospice? At least everyone understands hospice. And Abby's remark is she will be on hospice. The difference between being hospice and being on MAID or using MAID is that, on hospice, your end-of-life meds, your morphine, your Ativan, that may make you less present to your family, less present to your own experience of death. If that's an important thing to you, then maybe hospice is the lesser of the options. Of course, under hospice, you can say that you don't want morphine, but that's a distinction that people make. There's regional practice varies. I'm not going to go into a ton of this, but the beginning 1900s with eugenics advocates, people who wanted to euthanize folks directly because not necessarily even at the end of life, but because they were trying to select desirable traits in future humans, the concept of eugenics. And this was always an action by someone on another person. There was a Jack Kevorkian, I think we've heard about that in another presentation. He advertised in newspapers and he got a bunch of people that jumped in his van and used the machine. Like, he wasn't doing anything to anybody, he said, but his machine in his van, I think it was a Volkswagen van, in fact, allowed people to self-administer the medication. A bunch of years later, Jack Kevorkian was in and out of courts, et cetera. In 1997, partially on the basis of the Kevorkian case, the Supreme Court held that there is no constitutionally guaranteed right to die. The court left that decision to the states. And I think we've learned recently how well that has gone, not with medical aid in dying. Beginning with Oregon in 1997, states began adopting MAID laws. So, there's the 1997 one, slow kind of progression. 9 years later, Washington, right next door, has their Death with Dignity Act. Montana settled some case law, and that became known as the Baxter Act. So Montana was 2009. Then there was Vermont, then California, Colorado, District of Columbia, Hawaii, New Jersey, Maine, and then finally New Mexico in 2021. There are a bunch of states currently considering medical aid in dying laws. All of these. You find your state. Notice the statutory language: dignity, control, choice, options, aid. Our discomfort is reflected in our language. Words have meaning. Suicide, assisted suicide, euthanasia, those are meant pejoratively, and they're meant to cause people to have conflict around this concept. And actually, I think I'm always interested in talking to people that consider medical aid in dying an act of one on another, a euthanasia, or an act of one on self, a suicide. Because I wonder where the roots of those words. Is it in your religious background? Is it in your family's vocabulary? How does that even come up? Most people show a preference for terms that are more supportive, like hospice, palliative care, and comfort care. Here's John again. He says, "Will people think I coerced her?" That was his biggest thing, coercion and stigma. He didn't want to go back to the state where they had their early marriage. These folks were in my place in Steamboat, my town. They didn't want to go back to the East Coast and meet up with their friends who would ask him questions about this. So I want you to think about these questions for hopefully some discussion post this talk. Should MAID be available to people under 18? Should it be available to people with progressive neurodisorders who can't actually raise a hand to a mouth or can't swallow? Should mental and behavioral health challenges be allowed access to MAID? Anorexia and other eating disorders are the second most deadly behavioral health, considered a behavioral health illness after substance abuse. There's a woman an internist in Colorado who prescribes the medical aid in dying compound to 3 patients, none of whom actually lived in our state, but they all lived in medical aid in dying states. All of them had anorexia. One of them took the medication, passed. One of them died of malnutrition on the day that she was scheduled to have her family come in and visit. And so she was not able to do that on her own, but she did die that day under her own power. And the third person actually wrote an article with this internist that's been published that you can find in various places. It might be on my resources list if you want to look at it. I can point you to it. And her whole process was documented. She did use the medical aid in dying compound, and she did die with her family around her. Huge conflict. You know, should that even have happened? Does that happen? I mean, it's anorexia. You can't say there's a 6-month prognosis, although it's a debilitating illness. Should people with lingering physical conditions, like I mentioned before, cardiac failure or pulmonary failure, should those people who might live past 6 months, should they be able to avail themselves of MAID? And should people who are unable to self-administer be allowed to participate? Can they have help? And who should be allowed to help them? Heidi, I'm going to ask you to speak to that, if you don't mind. Just briefly, if you don't mind, during the question answer. I might have something in here about that. So, the patient advocate's role, has anybody ever been bedside for a MAID discussion or been bedside with MAID? You have? Great. Love to hear from you. And then would you, if it came up, would you know enough to be able to help your family maybe have this conversation? Obviously, you don't help with the medical aid and dying piece, but you could help set them up with resources and have a conversation with the family. And then could you, like if you would, could you actually do that? When it came right down to it, could you help with that? And the last question, you know, in this particular slide is, should you? It's still an open question as far as I'm concerned. Advocates come from all walks of life and all manner of experience. We hold varying values, different religions, different political values. Although I got to say, nobody's been very political here. I've been listening for that. And we have varying levels of comfort with clients and the various conversations that come up around clients in healthcare. I want to note that insurance and physicians are covered under most of these laws. Most of the laws explicitly say that providers don't have to provide and insurance companies don't have to provide against personal or institutional will. Most allow physicians to opt out, and federal funding under Medicare and Medicaid does not cover the services or the medications used in MAID. Some state Medicaid programs do, but the federal funds for Medicaid and for Medicare don't cover it. The cost is borne by individuals and families, and there are around the country various funding structures for folks who can't afford the medication. Patient advocates bear no obligation to discuss MAID. If MAID is something you can't support, find somebody that will. There would be somebody in your community that would know about this, a palliative provider, hospice, a PCP. If MAID is something you can support, then know the laws of your state. They're all out there on the internet. Find out if your clients' clinicians are supportive and encourage your clients to discuss with them. That's something that I talk to folks about when I first get to know them. After going through their advanced directive and what have you, and I ask them what they especially if they're critically ill, what do you think about your own death? Is that something that you think about? Have you talked with your family? Do they know what your wishes are should something happen to you? Even with my younger patients, like kids that get in skiing accidents, what happens if something happens to you on the operating table when you have your knee done? Is it something you've ever talked to your family about? So those are important conversations to have early and often. You all know this, 5 wishes or go wish games, discuss all the time, or often anyway, and review their wishes. If you're in a MAID eligible state, ask your clients to find out if their providers are willing to assist if that's something that's important to them. It's a weird question, but it has come up. It's come up in strange ways, not even people who are thinking about medical aid and dying. Clients don't need to have a terminal diagnosis to have these kinds of conversations. And it's great to encourage people to think about what their end of life is going to look like. Know about your available end-of-life options in your community. Do you have palliative care providers? Are they available? Does it take 6 months to get into one? Is there hospice care? Right now, our hospice is so full that they can't take any more clients. You can't have home care anymore, at least for another 8 months in my community. And this only gets worse as those of us with the gray hair in the audience age. So if people don't, I have one patient who just voluntarily stopped eating and drinking. That was an option that we discussed. We discussed with her family. Her family was very uncomfortable with hospice because they didn't want her on morphine, and the family absolutely wasn't interested in medical aid and dying. And she said, "Well, I'm going to do this myself then." And they said, "Yeah, you wouldn't be able to do it. You wouldn't last a day without eating." She passed away about 12 days later, peacefully. I mean, the first couple of days were hard for her, but very peaceful. Her choice, that was a great thing. And then refusal of care in a hospital setting. You can refuse, and your patients can refuse medication, procedures, therapies, nutrition and hydration. You can refuse that even in a hospital setting. What does it say there? It says terminally ill patients at end of life are legally permitted to refuse interventions for a long life. Okay, great. If you're talking to people about this sort of thing, choose your language carefully. It's best not to signal your personal beliefs. Wicked hard to do, but good to do. And practice non-disclosure. It's kind of social work 101. I didn't take that, but my daughter's a social worker, so she tells me this. Don't disclose, Mom. Don't say anything to anybody about your life. You can't really help it, but you try. And then use neutral language, neutral tone, neutral body, so that you're not transmitting your feelings about something. Obviously, our patients, our clients rely on us, and they rely on our guidance and counsel sometimes too much. And trying to stay neutral is the only way to deal with these kinds of conversations, in my opinion. Stay in scope. Depending on your background, MAID may not be in your scope of practice. Know who your resources are for client referrals. Educate yourself. And the advocate's job is to support the family and the conversation. It is not to provide or administer medication. It's not even to go and pick it up from the pharmacy. In our community, it's sent up by courier, a private courier to town. I live in a rural, semi-rural community, one that expands during ski season, but they come up and deliver it. They don't locally. We can't get it provided. I'm going to go back to Andy and John and Abby and Stephen for a second. Andy wanted help talking with her family. She and John invited their kids and a couple of close family members to come and have a conversation about what her wishes were. This took a bunch of months to arrange. Her daughter was in New Jersey, as it turns out. And during that time, Andy's health further declined. She was super weak. They had a long weekend of discussions. I got to participate in some of it to help with 5 wishes and the Go Wish games. They facilitated a hike. We carried her like in a fireman's carry for part of it. And we had great food. I cooked. Everyone agreed, and some reluctantly, to support Andy. And Abby planned a going away party. The medical aid and dying process was begun with Andy's PCP. Yeah. Andy died peaceful and easily on her own terms, awake and aware during her going away party. That was unexpected. I think everyone thought that I thought too, so did Andy actually. The party was going to be a way to gather her friends and family, a way to say her final goodbyes, etc. And then the next day, in the quiet and the privacy of her own home with her own kids, she'd do the thing. She decided to do it that afternoon on the patio. Abby, her daughter, is now training to become a patient advocate because she wants to help people at end of life. I just want to express gratitude. Andy's story is a composite of several of my personal clients. Nobody wanted to be named specifically, but to Andy and to all of the families, I am super grateful. It's such a profound experience to work with folks at end of life. And yeah, there's just a Creative Commons thing there.